Participants already joined. Sign in करो लेकिन join हो गया तो
video. Yeah, that setting. Yeah. Streaming will probably be of Series machine because it was not able to provide the stuff for us. And it was good because remove this paper. Yeah, background. Remove background. No,
it's downloading.
it's okay.
There's
Okay.
gone.
Not that bad. Not that bad. But small device. I did not test it for now. But it is. I saw it in one of the conferences in the exhibition. It depends on what you do. So it's a small machine.
कोई भी join तक फिर कहाँ पे आप पे please wait.
It's Chairpersons. You can put you say resume to register here or what?
Sorry,
We
sorry.
have Chairpersons.
Okay, we need about 3 or 4 people.
Take question or something like this. Okay.
Thanks.
So I will be here at the from my Zoom.
Yes, no, from here is not from here only. Admin.
So Chairperson should be here. You will take
Yes. Keep the laptop bit here.
It's the same no. They have to come here in a three person who are talking. One is talking and one is introducing or two is introducing here.
We can
Who is the attendee? So or let me say for
We have it. We have 6 months. But we use it for specific cases. We use it for one thing. And you have double that right to control catalysts, right side, left side, and it's been on the
not yet. I want to join myself only. 4634005. Why? Okay.
so you go inside with you. I'm give me inside. Give me the I'm give me inside. Give me inside.
and that's
Please wait, webinar will be being so.
Will begin soon. Allow us to get inside. Where to start? Open my, I opened it. Open my, share my screen.
Your screen.
Yeah. It's not my screen, it's a share. Why is it not coming?
Hello.
Do you hear me?
Okay. Yes.
Hello, everybody. Um, point of phone from me.
Yes. Equal.
Okay, you start to share screen.
Yes.
Share.
Share. That's it. You have to open the camera.
This is your talk, huh?
Yes.
It's open now.
Yes.
Hello, everybody. Today we have our webinar, and sorry for the delay. We have now past time around 10 minutes, but this was because of technical problem. We solved it soon. Now with me in the I have Prof. Alain Combes. He's the professor of the University of Liberté de Salpêtrière. He is in a visit for 1 week here in Saudi Arabia as a consultancy issue. Then we have also just Dr. Mohamed Azzam. He's a critical care consultant and the director of the National ECMO program in Saudi Arabia. And then myself, I'm Dr. Ahmed Rabie, a critical care consultant and the head of the ECLS unit in King Saud Medical City, member of Cluster 1. First, we apologize again for the delay because of technical issue again. Then now we will start with Dr. Azzam. He will tell us about the Saudi experience in ACLS provision. Then Prof. Alain Combes, he will talk about respiratory dialysis, e-course, CO2 remover, and the updates on supernova trial. And last, I will have my lecture on my talk on consensus statement for ECMO in COVID. So I hope all spending enough time with us. And now we'll start with Dr. Mohamed Azzam.
Good evening, everybody, and thank you for our invitation to speak in this webinar hosted by the Cluster 1 in Saudi Medical City Hospital. And we are honored to have a well-known figure, Prof. Alain Combes. Let me show you the Prof. Alain if you don't know him. There he is, but you'll see him after. And we thank the sponsorship company that provided this lecture and webinar, and Mufaddali company. I'm going to talk about what we have accomplished in Saudi Arabia, and my lecture is not really a scientific lecture, rather just to show what we did in the last couple of years. And I'm really impressed and honored to work with very, very respectful local speakers, local experts in this field that got us to where we are now today. I'm really proud of what we got, and hopefully with our colleagues, international colleagues, that we can get more input from them, and hopefully in the future we can grow and grow more. So my lecture will basically talk about introduction to ECMO, brief history, about ECMO service in ICU, and ECMO during the pandemic, and also our experience in Saudi Arabia. I'm in the position talking to very well experts, so I'm not going to spend that much time about introducing ECMO and history, but just as you know, just to start our slides. So what is ECMO? It's an extracorporeal life support giving to very sick patients that have failed the conventional therapies that we give to them in the ICU, whether they're cardiac cases or respiratory cases. The indication, as you know, is for cardiac cases and respiratory cases. And there's big two modes that we use in ECMO patient, which is the veno-arterial mode for cardiac cases and veno-venous mode in respiratory cases. So as we said, the indication is for respiratory and cardiac cases, and there has been a lot of different modes and a lot of different indication that has been. Sorry, 1 second. Why is it not moving, the slides? Because I think you're at the... Okay, sorry. Oh, sorry. Yeah, and of course, there's a lot of evidence. I'll spend a whole day to talk about all the evidence in ECMO, but I can tell you, once things reach to guidelines, that means there's a lot of evidence that support these services, and AHA guidelines already started to talk about even doing resuscitation or ECPR to patient with good outcomes. And our colleagues in France have pushed it further to do pre-hospital ECPR with very good outcomes. Just to give you an idea about the patient journey, you have an acute phase and you have a subacute phase, and then you have the chronic phase. And in Saudi Arabia, I think now we're very, very well structured in terms of the acute phase, where we retrieve patients in a short period of time, and we give them a good service, and we transport them to the high centers. You'll know about our high centers later. And even the subacute phase also, we give a great service in the ICU and in the hospital services, where we have rehabilitation, but built inside the hospital. And then we talk about the subacute phase, where follow up these patients in pulmonary clinics or in rehabilitation center and make sure that they go back to their jobs with a good function to be able to produce in our community. Of course, the numbers that I put, or the duration, is an average duration. There's people who stayed on ECMO for more than that, for years, 1 year or more than that. But this is the average where patients actually spend time on ECMO. History, of course, everybody's seen this picture in all international conference or all ECMO talks. This is probably the machine in 1970. It looked like a huge machine with probably a lot of complication, but that was a successful case that was done. It's a trauma patient that suffered chest trauma and was put on ECMO, and he survived, and followed by a case and a neonate. So to show you that we can do it in adult and pediatric. And then in 1989, the ELSO organization has been established, which is a non-profit organization to look at research and to collect data and to spread education and awareness about the ECMO services, and also to help to put international guidelines to people to know how to start a center and how to manage patient on ECMO. The biggest three steps that happened during the ECMO era is having these big pandemics, which showed that ECMO can support these patients and give them better outcome, less mortality. The SARS, the H1N1, and the MERS-CoV evidence. Again, this is a full day of talking about the evidence, but the landmark articles was the CESAR trial, which showed decrease in mortality in patients who were in the ECMO group, and also the OLA study, which also showed decrease in the mortality. Maybe there was some statistical significance issue, but again, looking at the numbers itself and the raw data, you know that there is benefit in the mortality for the ECMO group. The ELSO benchmark, which a national, international data registry with all ECMO centers around the world put their data, and you can see that the international survival is about 55 to 60%. Definitely there's center better than that, but this is as an overall survival rate. Now, why do I mention this? You have to understand that the ECMO patient, or the patient that need ECMO, are the sickest patient in your ICU. They are not just what you read. If you read about what is the mortality rate of an ARDS patient, you will see like evidence saying that between 30% to 35%. But this patient that you put him on ECMO, he's not a 35% mortality, he's like 90% mortality, 95% mortality. So these patients, if you don't put them on ECMO, they have a 90% mortality. But if you put them on ECMO, they have 50% mortality, or 60 or 40, depends on where you're working. So think about it. And this is important to people who work with the administration. When you want to talk to the administration, tell them, listen, if I did not do anything, he's 100% chance of dying. But if I put him on ECMO, I have a 50% of this patient living. And hopefully, of course, with the good outcome that comes, he will come back and function in your life. So saving a life is very important, and that's the message that we send to our administration. You see also from the ELSO recognized centers that the numbers are just increasing and increasing during the years. During the COVID era also, we had people thought, or I think we all think, that COVID was a bit different disease than the severe ARDS that we faced. They have multiple pathophysiology, just not just the simple ARDS, and that's why I think maybe this is the reason of the survival rate was less than what we see usually. So that's the benchmark of survival rate from the ELSO guidelines. Now we talk about Saudi Arabia experience. So this is the milestones since 2014 until present today, and what did we do during the last 5 to 6 years. I'll go in details in some of them, but just also that we established the Saudi extracorporeal life support during the year 2018, which was, I think, a very important landmark where we started the education, the awareness, the training, and this maybe made people get more enthusiastic and get more interested in what is ECMO. The other big milestone was having a central national program, which we'll talk about it more. So from 2014, 2018, ECMO services were available in a lot of centers, especially the National Guard Center, King Faisal Military Hospital, and these centers were serving their patient, but as individuals. So their patient, when they come to their ER or whatever, they will help them. There was not much of retrieval. During the MERS-CoV era, the MOH has purchased about 50 machines and were distributed on centers that will develop this service in the Eastern, Western, Central provinces. And basically, there was two major hospitals that were taking care of all the retrieval cases. So all the cases come to them. One in Riyadh, Prince Mohammed bin Abdul Aziz, and one in Jeddah, King Fahd Medical Hospital. And during that era, we published the first Saudi publication. Good. So good. We published the first Saudi article, extracorporeal membrane oxygenation for severe Middle East respiratory syndrome, led by Prof. Mohamed Azzam. And it showed that there is decreased mortality. So this was a propensity match study where they took the ECMO groups and matched them with the other cases that had the same sickness, who did not get ECMO. And as you see, there is a difference in mortality. In 2018, we established the Saudi Extracorporeal Life Support chapter, and we also had the first Saudi ECMO conference. I think Prof. Alain was there. That was in Riyadh. And these are the experts, and these are the leaders, and these are the champions that started this service. So they are from all healthcare sector. And I think that was a very strong point that we did, is we did not just put it to one center only. We actually talked to all healthcare sectors, and we had the leaders who work in this field together and sit and start this chapter. The vision, the mission, and the objective, as you can see, was basically, it's not just to teach, but hopefully during the years that we would be part of facilitating how to develop programs, how to develop centers, how to accredit centers, and how to give the service even. And that's at one point, alhamdulillah, worked when we joined with the MOH and started our national ECMO program. First, as I said, first conference in Riyadh. And a lot of courses. The first course was done by Dr. Alyaa in King Faisal Specialty Hospital, and then in Faqih Hospital, private hospital in Jeddah. And just the nucleus started. So there's a lot of courses that happened during that time. Even during the COVID, we did a lot of online webinar courses to spread the news. We also became more involved in international conferences. This was the SWAG Airsoul in Egypt, 2018. Of course, as usually, people go and give the lecture, my team, and I go to the pyramids and enjoy my time. That's my job, just facilitate and enjoy. And then in Dubai also, they have the Emirate Critical Care Conference. It's an annual conference, so almost now 16 to last year was the 16th conference, or no, last year was the 20th conference. And since 2010 and we are the one who always give the the ECMO courses in their conference. So all this happened up to 2019. The only thing that was, I would call as a weakness, was once the MERS-CoV disappeared, the two centers that I mentioned really suffered, because now everybody forgot about them. There's no support that is coming to them. And it was just, if I know Ahmed Rabie, hey, Ahmed, I'm calling you from the south. We have this case. What do you think? And Ahmed Rabie started doing everything, bring his car, put gas in his car, find a machine. And the same thing in Jeddah, Dr. Ahmed Rajab and Dr. Mohamed Shalabi. It was too much stress for them to be able to manage all these patients in an individual basis without any support coming from the MOH or other sectors. 2020 was the explosion. So thanks to the Chinese people, they spread COVID to the world. And because of that, I think that we did a great job in Saudi Arabia, to be honest, because we were on top of things from not just for ECMO, from the beginning. Once we heard it in the news, the MOH started to meet that at the higher level, even at the royal court level, people started to meet, how are we going to manage this? Prevention was probably one of the best prevention system that happened in Saudi Arabia. But regarding ECMO, so in January, we had a committee, a scientific committee under the umbrella of the MOH, which looked at, okay, if we get ECMO cases, what should we do? How much cases are expected that we will see? A lot of small studies that are coming and some statements from the international committees mentioned that trying to avoid doing ECMO during COVID, we don't have enough support or resources or beds to put patient on ECMO and then have other patients suffering because of that. So it's very, very tricky and very difficult to decide whether we should start this ECMO server or we just say, no, we don't have ECMO in Saudi Arabia and we just manage them conventionally. So we estimated maybe during the COVID era, we'll probably see somewhere between 200 up to 600 cases during the next 2 years. So the supply was purchased based on that, and also extra machines were based on that, ordered on that. March was the first case was put on ECMO, COVID case we're talking. I think this was done in Tabuk, I think it was in Tabuk, the first case. And then, no, that was, sorry, not in Tabuk, I think it was in Riyadh. The ECMO hotline was established, and we'll talk about this, the 1937 service, during July. We were working as an ECMO hotline, but still we did not have a well-established program. And then July and December, we established ECMO hotline, and we had new 3 centers that serves the ECMO, Tabuk, Najran, and Medina. And that's also was a big challenge, because again, you have the international expert during the war stating that that's not the right thing to do during an ECMO. I think what helped us, we did not have the load like the European countries or the North American countries in terms of burden on ICU, again, because of good prevention from the beginning. Plus, we were a lot of people who were happy to go and help these centers and stay with them for a period with an online supervision. And I think we published something of this and showed that there was no really bad outcome in this center compared to the expert centers. Now, it is biased because even these new centers, they were actually calling the expert people and managing these patients with them audio-visually on the phone. Sometimes we have to go and come back. So again, you can say that it's kind of had the expert supervision. That's why I think they succeeded. My assignment was done in, my nomination and assignment to be the MOH ECMO leader was during this period, probably March 2020. And from that, January 2021. And from that, we developed a committee under the program, which had expert physicians, nurses, and perfusions to start putting guidelines and putting protocols for the service. The first goal actually was, how many machines do we have? Where are these machines? Are they functional or not? And we spread the news to all the centers through official communication to tell us exactly what do they have in terms of machines and in terms of supply. We had at that time 72 machines inside the country with different companies. We made sure what are the codes, so that a lot of homework, to be honest. You cannot understand how difficult it is. Actually, not being a doctor, you're actually working as a medical supply person. So you want to know what's the code. So when Dr. Alyaa or Dr. Ahmed in his hospital wants to order a membrane, okay, I need this membrane, but what is the code? Do we have a code so we can communicate with the supply chain and get them? So we establish all the codes for the ECMO supply in our country. Our number 3 goal was to put policies, procedures, accreditations to centers. So if they want to open, I think we did not reach yet to the accreditation part, but we're very close to do that. And we developed our flow chart for how to accept cases for ECMO. And this chart was used also in the MOH ECMO hotline as how do we take cases. To be honest, it was most of the indication criteria is coming from the EOLA trial with maybe mild modification. When we started, actually, and another challenge, we said that any patient who is less than 45 will get ECMO. Anyone who is more than 45 will not get ECMO no matter what. And I was harassed by that from everybody. I got threatened calls from everybody. What the hell? You mean you will let me die? My colleague, you will let me die? I'm 45 now, so probably I would have not got ECMO at that time. So that's the thing. It was very difficult because really we did not have data and we did not want to overwhelm the system, and knowing that internationally getting supply was a very difficult thing. But once the cycle has moved, so that's important. You have to review, you have to keep on reviewing what you're doing. If what you're doing is right, continue. If it's not, then change, and you have to be flexible. And to be honest, I worked with an amazing team, with the best team I've ever seen in my life. They are so flexible. They're also available at any time. Eid al-Fitr, this is the last day, the first day after Ramadan. And this is like Christmas or New Year. We go to pray Eid at like 7 o'clock. This is like the big celebration. And we were still having meetings. Ask them. It was 6:30. Okay, you know what? I need to go take a shower and wear my tube to go. So let's stop. So imagine, even during the holidays, these people were just working so hard, and really appreciate their work and their commitments to reach what we reach. So I really thank all the people who made this happen. We developed some guidelines under the umbrella of MOH. We can share with the people these guidelines, and it's on the website. I'll give you the link. So this is actually later. The one that we started first is with the practical guidelines for COVID cases. So to give the preface, so that's not a real, you cannot use these articles to manage ECMO patient. This was more like a selection criteria guidelines. So people in the periphery, imagine there is actually hospitals in our country. There's not even an ICU consultant in the ICU. There's an internal medicine specialist or an anesthetist that's managing ECMO. So they have no clue about this. And that's why we needed to give them some guideline, at least to call us. So something just to catch them, and they talk us, and we help them to either decide to take these patients or just manage the patient in their centers. And I'm proud of this slide because from 2014 to present, we were just 2 centers. Again, we're talking about MOH centers. Now we're 13 centers that are providing the ECMO service in Saudi Arabia, all over Saudi Arabia. Geographically, it helped us a lot to decrease the cost of taking patient by planes. Now we don't need to do flight or aeromedical transportation less. We do it less because of having more centers. And all these are supervised by the MOH program. The 1937 ECMO Hotline Center, that's basically the big step that we had. This is under, in Arabic, المركز السعودي للمواعيد والإحالات الطبية بقيادة الدكتور نوفل الجريان. They provide hotline services, not just for ECMO, for ER, for ICU, for PICU, toxicology. And they were very kind to accommodate us under them. And it's a 24/7 service. We have ECMO physicians. They are ICU physician and cardiac surgery physician, perfusionists, life specialists. Life specialists are the administrative people that are working the hotline to get the calls. So they're like the dispatch team. They take the calls, they take the information, they make them fill a specific form. And this after they contact them with the ECMO team on call. We are 19 ICU consultant, 5 cardiac surgeon, 30 nurses, 23 perfusionists, 9 respiratory therapists, and 40 life specialists. And this slide was last year. I'm sure we're more than that now. We developed a pathway of how to get the calls. We want to develop KPIs to see, okay, you know, from getting the call until you actually retrieve the patient, we should do this all within 6 hours. So that the trip from taking the patient, from getting the first call until the team moving and getting the patient should be less than 6 hours, divided to different steps. So from getting the phone call, from the consultant answering, from activating the team, and this was for ground patients. But we also have one for aeromedical. Again, aeromedical is difficult really because the booking the flight is not really in our hand. It's the Ministry of Defense who give us the planes. So sometimes it's not easy and to book a plane. It depends on the weather and depends on their commitments. They have improved a lot. I will tell you from very difficult to communicate to them until 2 years later, when I actually stopped the plane. I was in the airport. And our plane had to leave for another emergency case, but there was another plane taking a ward patient. So someone was getting moved to ward patient, and the pilot saw me. So I listen, can we take our patient before your patient? Oh, I will talk to the family. Don't worry. Well, if you convince the family, so I went and talked to the family. They're very nice people. Again, this is a very Saudi culture. We are very helpful people. Our population will always sacrifice if they know that this is a serious situation. So the son said, listen, it's okay. As you're sure there's another plane that's coming at 100%, I will follow, take my phone number, I'll follow that. And we actually took his plane and went. So the people started to understand how serious this service, and they were able to put all their effort to make this service succeed. So this is hand. Inshallah, yes, I'm just collecting some money and I'll buy them stuff. So we have a dashboard, but it is not an official dashboard yet under the MOS, but this is hopefully how is it going to look, looking at all the cities that have the ECMO and the hospitals, showing what cases they are doing, showing some KPIs, ECLS survival, 90 days survival, what type of cases are we doing, also looking at the years, how much cases are we doing, and if it's going down, it's going up, to understand what's the situation at the national. So it is not like a hospital KPIs. The hospital are more interested in the management and the quality of the care and what are we doing in the complication. This is, we're looking at the national level, the important information for us to understand, okay, is this service worth to continue paying for it and maintain it? So our ECLS survival, so how many cases? We're almost 800 cases. And this is the survival rate. So ECLS survival, meaning up to removing the patient 48 hours after the decannulation, 67%, which is, again, as you saw internationally, that's a good number. There is varieties between centers, but that's the overall survival rate. Our 90-day survival is less, unfortunately, it's 43%. And that gives you an idea. Maybe there is a lot of things that we need to fix in our ICUs to make sure that even post-care, our ICU or hospital care need to become better so we don't have loss of patient. Our crude observation is it because of infection, really. It's a lot of sepsis, it's a lot of MDRs. And just remember, where are these cases coming? We took patients from very small hospital, no infection control. So they come with weird bugs that we saw. And that's probably one of the reasons that they had high mortality, but that's not a solid scientific observation. This is the different outcomes of the patients. So the recovered patient, again, this is after 90 days. So 37 patients, some of them died in the hospital, 19%. Some of them died within the 48 hours from decannulation or on ECMO, so 30%. And so there's about 1% still in the hospital, and 13% unknown is just because we did not get the data for these patients. That's why we know that they were on ECMO, but we did not get the final outcome for them. This is an interesting slide, and I think it's an important slide because, again, the administration, how long this patient is going to stay on ECMO? We need the bed, we need the ICU bed. So, interesting. So they did not stay too long on ECMO. So your VA ECMO was, so average length of stay on ECMO was about 10 days. And for VAV ECMO was almost 8 days, and for VV ECMO, less than 20 days. And their length of stay in the ICU also was not that bad. So almost less than and for VV ECMO, it's about 30 to 35 days. So again, they're not they're not staying too long in your ICU. That means that's not, you don't have a lot of burden on your ICU because of these patients. ECMO retrieval case was almost 80% of the cases were ground transportation and 20% was flight paramedic. And also we retrieved patients from outside the country. So from Kuwait, from Jordan, we had a case from Egypt, we had a case from the States. These are Saudi people who are living outside the country, and we went to retrieve them to bring them. So we do some international retrieval. The MOH program. So again, a lot of work is done, but we will never be well recognized unless if we start publishing our work and people recognize us internationally. So we had some local publication and international publication. These are some of them. The implementation of a new ECMO center during the COVID-19 pandemic experience was, I think, for us is an important study that was published, and it made people change their mind a little bit about how should we develop a new ECMO center in specific circumstances during a pandemic. A consensus has been made with a lot of international expertise about management of ECMO in COVID-19 severe ARDS, and that this was published recently. So these are some of the scientific publication. We had 2 international conferences. The SWAG ILSU for the first time was hosted in Saudi Arabia in Riyadh. And I think Alex attended the conference in the airport. Unfortunately, it was a big mess and we couldn't catch him in Saudi Arabia at that time, but alhamdulillah, now we have him with us here and hopefully we'll see him more in Saudi Arabia in the future. And the Saudi ECLS conference that was held in 2023, also in Jeddah, with a lot of international speakers. What's the future? Establishment of a national pediatric ECMO. Keep tuned. Very soon you will have an ECMO program. The leader is hiding in the back, Dr. Ahmed Azzam, one of our pediatric ECMO experts, and hopefully soon we'll hear that we have a national ECMO pediatric program. Developing a national ECMO data literacy. I think this is very important. We already started working on this with the collaboration between MOH and the Saudi Health Council. And we already have all the data variables that we need to collect. And this will facilitate a lot of contribution with international organizations. So instead of asking each center to send their data, it will be easy, one communication between that center, of course, after taking the permission of these centers to give the data internationally. And to have a structured training for all healthcare providers, fellowships, diplomas, again, with the support of our colleagues internationally and with the Saudi Health Commission. I think it's time to have our own programs and fellowships and diplomas to increase the service. These are some of the KPIs that will be established and will be collected from all centers in the near future with the Saudi Health Council and the MOH. Some of them are clinical performance KPIs and some of them operation. So as you know, the ECLS survival rate, survival to discharge from ICU, survival after 90 days, and the ECMO cessation due to major complication. And if you notice, I don't know if you can see my, yeah. We actually benchmark them. So you will not find in the literature studies that give you benchmarks. Maybe the ECLS survival, just we think, okay, this is probably the best. If you want to be like the other center, you should have this. But nobody really have a study or a publication that tell you what your benchmarks. Maybe in the centers itself locally, they have some kind of benchmark. So from our Saudi experience, we came up with these benchmark. And this is the blue, the green, the yellow, the red, the MOH people who work, they probably know what is these. These are every KPI in the MOH, go through these colors. And once you as a director see red, you start screaming and yelling and tell them, I need to see it as green or blue. I don't want to see red. So again, we kind of put some benchmark for these KPIs. The other thing is Operation ECMO. So circuit oxygenation consumption per patient rate. That's something the medical supply would like to know, so they can figure out how much supply they can order in a tender at the end of the year, and also to follow up. And if you are a center putting a patient who's on ECMO for 1 month, and you tell me that I put 5 circuits, what's going on? There's a problem. So maybe the patient needs it, but if this is a trend in your center, then we need to discuss what are you doing. ECMO machine readiness rate. Some of the machines need maintenance, some of the machines are out of service. So following these numbers, if you have 10 machines and you tell me that 80% of them are not working, what's going on? And ECMO length of stay in the ICU. So my take-home messages, ECMO service is becoming a standard of care for selective critical ill subset of patient, and I have a feeling, or I'm a bit biased, but I think in 10 years from now, maybe we're not going to put ventilator, we'll just put ECMO. But it is becoming a standard of care. The role of national program and centralization hub serves in better clinical selection and outcome, better understanding of ECMO centers and needs and distribution, better supply chain and ECMO devices utilization. And I think we need more evidence needed to study this concept of centralizing services of ECMO rather than just having it in specific hospital. By that, I end my lecture, and I'm really happy that you guys are here, and I'm honored to be with you. And I thank everybody who got us to this point. A lot of soldiers, hidden soldiers that did a lot of work. If I start mentioning names, I will never end the list, but they know who they are, and they are the leaders. And I just facilitated how to talk to each other and how to be able to communicate, and that was it. I really thank Prof. Alain for being here, and Dr. Ahmed Rabie for this nice webinar. And unfortunately, I will continue following the webinar with you online, because I actually have 2 other meetings to attend to. But my spirit and my phone is with you, inshallah, at any time. Thank you very much.
Thank you very much, Dr. Azzam, for this presentation. You're describing the work of so many across the kingdom in a period where many were believing in ECMO, and I think all of us, we had some discussions, some convincing to do, but now this is, as you said, the standard of care, and everybody is working towards it. To have it. I see a lot of people even going for fellowship and training and coming. And we thank the ministry for adopting this program and growing with such a fast rate. Do we have any questions from the audience? Ahmed, هذا كمبيوترك؟
For the sake of time, if you can
start now. And if we don't have any questions, we can proceed. Okay. Okay. Prof. Combes have flown all the way here from Paris. While once he's done, we'll all fly back to Paris with him to spend better time and weather. Such a royalty, I always call him that, in ECMO, where he have not only built the foundation for ECMO, but actually even moved forward into the development. And I believe the next step is not veno-arterial extracorporeal or venous extracorporeal oxygenation, but also the respiratory dialysis, the CO2, and what's beyond. So we're so lucky and honored to have him here. And I'm not going to delay you much, and we will start. Thank you. لا نطلع كذا طيب.
So thank you again for first this kind of introduction, and it's a very great pleasure and honor for me to be here with you this week. Just I'm going to. Is it okay? Okay, so ECMO, extracorporeal CO2 removal for. That's great. Okay, it's very good. So first, let's review together the latest classification of ECLS system. And now actually ECLS is an overarching term covering both ECMO, both cardiac ECMO, VA ECMO, respiratory ECMO with VV ECMO, and the hybrid ECMO with VVA. And ECLS as a form of extracorporeal CO2 removal, which only provides CO2 removal, was historically AV ECMO with a pumpless device, and now it's VV ECMO with a device which is also run by a pump. So those two devices, they actually use a very similar technology, but with different objectives, and those are here explanation of how those gas exchange device work. ECMO provides full oxygenation, but you need to get blood flow in the ECMO machine, which should be between 3 and 4 liters to reach sufficient blood oxygenation. Below that threshold, there is much less oxygenation. And on the other side here, on the left panel, since it's 20-25 times easier to get rid, to decarboxylate the blood and needed to oxygenate the blood, even with much lower flows, you might get a very decent blood decarboxylation. And even with blood flows less than 500 ml per minute, you may reach close to 35 to 40% of CO2 removal. This is something we have shown here in H1N1 patients during the latest, the first pandemic worldwide 10 years ago. We showed here that to reach full oxygenation, there was a need to reach a blood flow in the ECMO machine, which has 60% of the cardiac output. And we also showed that the sweep was the main determinant of CO2 removal. When decreasing the sweep here, very sick patients, all white lungs, H1N1 patients, when decreasing the sweep from 10 to 2, there was no impact on the oxygenation. Still, on the right panel here, you can see there was a steep increase here in the PaCO2 respiratory acidosis here. At the same time, there was an increase also in the pulmonary systolic arterial pressure, which is a physiologic mechanism which is associated with apnea. So on that slide, you can see the main determinant of CO2 removal. First, the gas flow, as I showed you just on the previous slide. Of course, the larger the membrane, the higher the efficiency at removing CO2, the blood flow also. There may be some kind of threshold reached when the blood flow reaches 800 to 900 ml per minute. Above 1 liter per minute, there's still some improvement in the CO2 removal, but much of the benefit here is between 250 and up to 1 liter per minute. And the baseline CO2 counts also if you want to measure the total amount of CO2 which is removed by a machine. This is why you may want to normalize the global CO2 removal rate by the baseline PaCO2 to have an idea of the full performance of the device. So we have those two types of ECLS device, ECMO, which uses large cannulas, high blood flow, large membranes, full blood oxygenation and decarboxylation, but high technicity might be limited to ECMO center for better care. ECMO might use double lumen catheter instead of large cannulas. The blood flow might be more limited, up to 1 liter, 1.5 liters per minute. This might be called respiratory dialysis actually, because it's sometimes CRT machines which may be used to provide ECMO in the ICU. The blood oxygen, the membrane oxygenator is usually smaller, between 0.5 and up to 1.5 square meter. Of course, if the blood flow is below 2 you might not get significant blood oxygenation, but blood decarboxylation may reach up to 70 to 75% of full body production, the VCO2 of the patient, with the larger membranes and the 1 liter per minute blood flow echo device. And of course, this may be used in regular ICUs because you can't provide CRRT in a regular ICU. So why not providing respiratory dialysis with those machines? The story began years ago now with Alyaa, a pumpless device. You may have been aware of that device, which was draining the blood from the arterial side. There was no pump. The blood was run through the membrane oxygenator and returned to the patient on the contralateral femoral vein. This device is no longer available. Still, the membrane now has been put on a device which is an ECMO machine. Basically, it's the machine you have here in the room. There's two different types of devices. Those were derived from CRRT machines, which are mostly run with roller pumps, like those which are on that slide. And also machines derived from ECMO machines. The CardioHelp might be run with a 5.0 kit, which is a 1.2 square meter. And the Alyaa active device, which uses the Alyaa membrane, is a VV echo device, which provide also a lot of CO2 removal with those Alyaa membrane. So what is the rationale now? What is the population of interest? The first one is COPD patients. Of course, it's easy here. Those patients have baseline elevated PCO2. When they have decompensation, the PCO2 even gets higher and higher. And echo here is used to prevent intubation and failing of non-invasive mechanical ventilation, leading to invasive or to allow rapid extubation in those patients who have already been intubated because of a failure of NIV. This is here one of those patients in my ICU, a COPD patient who was able to walk out of the bed very rapidly after being treated here in the ICU. And there was quite a few studies were published on that subject. This is one of the Italian study with a small machine. It was a machine that was derived from a CRRT machine called the DECAP Smart. The blood flow, as you can see here, was highly limited, only 250. And they applied this device to COPD patients at risk of NIV failure because the pH was not controlled after 1 hour of NIV, or because they had a high respiratory rate, or because there was the use of accessory muscle in these patients. So what they did is to treat 25 patients with the echo device, and they used their database to have controls who did receive only NIV. And they looked at the outcome of these patients. And actually, there was less need for intubation in those patients who got echo. And when looking also at the mortality, there was a trend toward lower mortality. It's fragile data here, only 20 patients in each group. But still, it's very interesting data here about the potential for salvaging these patients. And there's many more to come. This is a study running in the US, the Vent Avoid, with the A-lung device. The Vent Avoid was supposed to randomize up to 500 patients, probably will be stopped before that point, but we might get some significant information for that trial. And we have a trial in France, also with the Xenius device. It's called the CORAI trial. Also two types of patients here, those at risk of NIV failure, those who have already been intubated. ECOR is applied, and we hope to decrease mortality also with that technology. Of course, second population of patients, ERDS. In terms of number of patients who might be treated with ECOR, it's probably 1 to 10. We have a lot of ERDS patients here who might benefit from ECOR. And the rationale here is to decrease the intensity of mechanical ventilation. Baseline PaCO2 is in those patients is very close to normal, maybe up to 50 meters of mercury but it's completely different here from COPD patients. What you're going to do is to decrease the intensity, to decrease minute ventilation. Doing that, it's creating respiratory acidosis by hypoventilation, and you're going to control hypoventilation with the ECMO device. We have a lot of data from previous trial in ERDS. We also wrote this review paper in JAMA with Dan Brody and Art Slutsky about what might be ECLS use here to decrease the intensity of mechanical ventilation, to minimize lung stress and strain by decreasing ventilators-induced lung injury, by decreasing the volume trauma, by the volume, the pressure, barotrauma, atelectrauma, and biotrauma, the cytokines which are produced within the lungs in patients who receive aggressive mechanical ventilation. There's many papers also about the impact of the driving pressure, which is believed now to be one of the most important targets for patients under mechanical ventilation, with the threshold of the driving, which is the difference between the plateau and the peak, with the thresholds above around 15 centimeters of water, above which the mortality exponentially increases. Also very interesting data about the respiratory rate here, where the increase in respiratory rate just by 1 beat per minute might be associated to a 3% increase in mortality. It's huge. It's probably a threshold around 25, 27, above which it becomes highly significant. Those are data from the big observational lung safe database, highly convincing data here, and also data from animals here, which received either ARDS net ventilation with a respiratory rate, as you can see here, as 30 beats per minute, and the respiratory rate was decreased to 14 in the experimental animals, and respiratory acidosis was controlled by an ECMO device. So same VCO2 in control animals was only performed by the vent, but the respiratory rate was high, and in experimental animals, it was controlled by the vent plus the ECMO device to reach the same CO2 removal altogether. And when they measured the pro-inflammatory cytokines within the BAL fluid in the lungs and in the blood, this was lower for those animals who were treated with lower respiratory rate controlled by the ECMO device. Very interesting data here also for the future. You might want to integrate all this information in one single variable, which is called the mechanical power, which involves the tidal volume, the driving pressure, the flow, the PEEP, and the respiratory rate. The formula here is quite complicated. You might have a simple one to be used at the bedside, and also very interesting data here showing that also might be a threshold in terms of a mechanical power, maybe around 17, 18 joules per minute, the unit of the power here. And those are data from ECMO patients. Look here, the power just before ECMO in those patients was above 20, around 25. It's much higher than the threshold of 18 I've showed you just before. And if you set up ECMO, but it's the same for ECHO, it's ECLS here, you can decrease the tidal volume from 6 down to maybe 3 or 4. You can decrease the respiratory rate, you can decrease the plateau pressure, the draining pressure, the mechanical power altogether to less than 10, and to be highly protective. So this is why we have this evolving paradigm here. And respiratory dialysis with ECHO might allow you to reach much safer mechanical ventilation in these patients, which may translate in less deaths here in your ARDS study patients. Well, we have some studies. I will show you some of these. This was one of the first here. The extravent was done 10 years ago, more than 10 years ago now. It was done with the AV shunt, the Alyaa AV shunt. The study randomized 79 patients. There was 40 echo patients in whom the tidal was decreased from 6 ml per kg body weight to 3 ml with the high PEEP ARDS net strategy, and the control patients were ventilated using the classical ARDS net strategy. Overall, and no difference in the MV3 days. But very interestingly, when looking at those patients who had baseline PF ratio below 150, this time there was a benefit with much higher number here of MV3 days, both at day 28 and at day 60. And then we decided to launch the Supernova initiative. 2 steps. First, a pilot study we did a couple of years ago, just before the COVID, and we published that paper in ICM. There was overall 95 patients here, 2 groups here, high flow devices, the Mackay and Novalung patients, and the lower flow device, which was the A-lung, which was tested in that study. So basically what we did is to decrease the tidal from 6 to 4. There was a target also for the plateau pressure to be decreased less than 25, and was decreased actually from 26 to 23. At the same time, there was a need to increase the PEEP to keep the same mean airway pressure here to prevent de-recruitment, because obviously this is one of the potential risks of decreasing the intensity of mechanical ventilation. And this is what we did here. The PEEP was increased from 12 to 14. And if you decrease the plateau, increase the PEEP, the driving pressure is going to decrease a lot, and was decreased from 13 to less than 10 in these patients. PaCO2 and pH were controlled by the core devices. And here also we got a specific analysis in detail comparing those 2 types of devices, lower flows versus higher flow device. And obviously the target, which was here reached more frequently with the higher flow device, which provide more CO2 removal. And look here also, the respiratory rate was controlled more efficiently with the high flow device. And it was actually possible to decrease the respiratory rate, which was not possible with the lower flow device. And the AC dose is also more efficiently controlled by the higher flow devices. Well, still there was some adverse event, was mostly limited to the cannulation site, mostly small hemorrhage at the cannula insertion site. And actually there were less complications with the high flow device than with the lower flow device. Might be also specific complication here with the lower flow device related to hemolysis within the pump. So we concluded that was possible, feasible, and reasonably safe to do that at the bedside in ERDS patients. We also reanalyzed this study to determine what might be the inclusion criteria in the future trial. We tested the PF, overall dead space, static compliance. All these factors may be also used in the future for including patients in an RCT. We're working on that right now. Busy slide here showing that using this, what has been called predictive enrichment strategy, selecting the good patient for the strategy might allow you to include less patients and to have more success in those who are included. So we need higher evidence. We got some from the UK REST study, was published 2 years ago now. They included ERDS patients and also acute respiratory failure patients with a PF below 150. The study was planned to enroll 1,100 patients, but it was stopped in March 2020, just before the COVID, only after 412 patients had been included. I will explain you why the study was stopped. First, have a look together to the patients they actually enrolled in that study. The PF was 118, 115, so very severe, close to severe ERDS here. The PF is on the low side. Still, there was very few patients who did receive prone positioning. The PEEP, only 10. Usually, the expected PEEP in those patients is between 12 and 14. And also, the driving pressure, the median was less than 15 in roughly 50% of the population. So we might question the target population here. Was it the good population of patients? Second, they had to stop the study for 2 reasons. The first one, there was a trend in one group for higher rates of brain hemorrhage. This is why they convened the DSMB to analyze the data. And there was, a small increase in the number of patients who did have brain injury, but it also analyzed the survival rate and was no difference at 400 patients included. So based on those two information, they decided to stop the study. This is here the main figure about the outcome, showing that 90-day mortality was 41 versus 39, so no difference. And there was actually a bit more 3 days also for ventilation alone patients, which might question the result of that study, and also a trend toward more need for ECMO, not significant here, but a small trend to need more ECMO with these ECMO patients. And as I mentioned before, the rate of brain bleeding was a little bit higher in the ECMO group. So, wow, this study has many limitations, and we need to analyze these limitations to build up the next one. First, the power is very low because they had to stop the study very early. But this is, for me, one of the most important information here. The decrease in the tidal volume and the driving pressure was quite limited. Probably because the device did not allow them to go below the tidal was only 4.8 from baseline 6. And the target should be less than 4, maybe 3 in these patients. So they did not deliver here. And the driving pressure also, the decrease was highly limited. I told you that the 50% of the patients at the driving less than 15. And when looking here at the difference between the echo group and the control group, this difference was very small, 1.5 centimeters of water. So they did not separate the two groups. So they did not provide the true reduction in intensity. Last but not least, they had to increase the respiratory rate in echo patients because the machine was not sufficient, despite the fact that, once again, the decrease in the intensity was small. They had to increase the respiratory rate, and they did not control well the PaCO2. Also, the recourse to bronch positioning on echo was quite low. And once again, the TF here at baseline was 115. So explaining why they may have observed more than expected, higher than expected mortality in their patients. The last big issue is that most centers did not have experience also with the device. And obviously here you need training before running these type of trials. This is the latest paper published just a couple of days ago in the New England Evidence. It's a new New England family journal based on the rest also, and they reanalyze the rest. I will make it short. The paper is very interesting, but it's quite complicated stats. But they did two very important information about the predictor of success or failure of the technique. One of the good predictors is the ventilatory ratio. You have the formula here to calculate the ventilatory ratio. And when this ventilatory ratio was above 2.8, there was a benefit with ECMO, which was not the case if the ventilatory ratio was lower. Ventilatory ratio is close to alveolar dead space fraction. Same for the PF. Very interesting data here. You can see that if the PF was below 100, the mortality was much higher with ECMO. Once the PF went up over 100, there was a benefit. And the higher the PF, the higher the benefit. These are interesting data here. Compliance, elastance, no difference. So this is the conclusion of that paper. And actually, we are using these data now to also determine what's going to be the entry criteria for the big supernova RCT. We are working right now. These studies should be able to start, let's say, in the 3 to 4 months from now. So this is my conclusion here. Respiratory dialysis is possible. There's a strong rationale both for COPD and ARDS patients. But before we can diffuse the technology widely, widely. We need to work together, build registries, and work also on RCTs here to have more strong scientific evidence. This is my last slide here to our meetings and training course in Paris. Thank you so much for listening.
Thank you, Prof. Alain, for a very interesting presentation. If we have any questions from the audience? And okay, so most of the comments are not questions. However, those who are joining online, please, if you have any question, drop it in the chat box. Mali?
Thank you. Either what is not big difference in the expression or as the driving effect. I want to ask what your guide or go down with the tidal body, go down with the driving pressure. Have any criteria to go down with the intervention or just
Thank you so much. Actually, just answering a question here. This is on what we are working right now for the next supernova. The decrease in the driving should be at least 5. We probably are going to target patients with driving pressure above 50, and the plan is to decrease at least 5 by protocol. Same for the tidal volume, but everything is linked here. The driving, if you have a high driving with this limited decrease in the tidal, let's say from 6 to 4, you might have a significant decrease in the driving pressure as well. But I do believe 5 to 6 centimeters worth a decrease might be needed to get the best results possible. Let's say the target should be around 10 centimeters worth of drive, if possible. And once again, this can be reached only with a small device, meaning at less than 5 mm per minute. You will need to increase the respiratory rate maybe up to 30, 35, with all the limitation of that and the active mortality. We know that increasing the respiratory rate will be associated with high mortality.
I might ask a couple of questions. I do understand the need of segregation between the two groups, so you can build the difference and you can see the difference. To reach a driving pressure of 10 and below, you're almost APRV. So did you consider putting an APRV as a mode of ventilation and getting rid of the CO2 by the ECMO? I know but I believe the ARDS, if it is
we have a study conducted in France, not published yet, comparing APRV, but not with the inverted I/E ratio. The I1 to 2 normal ratio. The study not published yet, but did not show the difference between volumetric control and APRV, which is the form of for ventilation. So probably we'll stick with the classical VAC, volumetric ventilation, targeting a tidal between 3 and 4, and probably the most important point here will target the driving, let's say at least 5, 6, and to reach, if possible, 10 or a bit below 10.
And the increase of rate while you are using ECOR, that was a little bit unusual. Was it flow restricted? Is the surface, the surface area of the membrane? What was the limiting factor?
For the rest study, there's many limitations here. The flow was limited at 400. The membrane is only 0.6. You know, the Alyaa membrane is going to use this 1.2. It's 2 times the surface, and the blood flow will be 3 times the blood flow. So you may provide at least 2 times the CO2 removal rate that was provided in the rest study. It's So the higher the CO2 removal rate, the higher you can, the bigger you can increase the intensity of mechanical ventilation for research.
coming with the ABRT. I think combining ABRT with core.
I tell you why we care about it, because we have a lot of people. We have, I'll tell you the history one. 2016. Patient must be DNR and everything has been tried. And this ratio, high frequency, and we use ABRT without a spontaneous mode. Just paralyze them, have them on very but not recent because even the VRT low, yeah, the what was it, 0.3 seconds? It's great, it was not. And we used to torture them with that, a lot of pneumothorax. And once you have good chest tube, so I think the experience here, because the resistance is ECMO prior, you have a lot of people more expert than ABRT than if I'm not mistaken.
We have to have
The trainings we have, how many times do you use ABRT? Rarely if ever. Okay, so just 5 people to do that. Okay, so from 2018-19, we are very high frequency all the time. And how we are using it. It was actually one of the requirements of the white paper that you with 3 high frequency. So I think that's what you will find some people thinking about.
This is the mode we are using. But it's ABRT, it's the mode ABRT. We allow some and instead of the inspiratory expert ratio 1, and then you have the rate and so not really with control of the respiratory and also control of the and yeah, the main advantage of this APRT mode, we have trigger ventilator. On this ventilator, the advantage is that it's not synchronized in the spontaneous respiratory flow of the patient. So there's much less risk of swing of transport pressure. If the patient makes a small inspiratory flow, then at the same time the breath, the vent air, you might have a swing close to 50-60 centimeters water driving. With the RPRV, there's no synchronization. So the patient can breathe a little bit on top of the 2 level pressure without stress. Wow. We don't know now. Grounded. We have 2 types of mechanical ventilation. One with the PRV, one with the almost apneic ventilation. You know what is better. But probably not the same. Yeah.
So one last question, I think, from my side. I believe in the REST study, one of the biggest problems is the inclusion criteria. And you see others where they update the inclusion criteria and protocol. BF ratio below 50. That's practically ARDS. I wouldn't put a regular. And actually, that's why in our protocol that we built with the colors is that if you have a CO2, while the FI2 requires 80 and above, not even 100, we go for ECMO. We go for ECMO. And I think that's why I think REST have done worse to the idea of ECMO by making it less appealing. People will start just cursing it. Yes, that's how. That really. Any other questions? I'd like to come for that. Well, we would love to be a inside of you.
Well,
Sorry.
thank you. Thank you, Prof. Alain, for this kind lecture or talk about CO2 removal, which I think it will be the future of the management of severe RDS after supernova. Please. Okay, I will go quickly through our last consensus of expert opinion on utilizing our ECMO provision during COVID-19, despite it came somehow late after the COVID pandemic stopped, but we hopefully think that it will help our future coming generation during the future pandemic. We don't know we will be of them or not. So this is a disclaimer. I start every time that this consensus has an evidence which is lower than the guideline. I mean, we should not consider the statement here in relation to the randomized control trial and other high quality meta-analysis, and for sure the ELSO guideline. I will go through this consensus because it's too late now, but I will highlight on the methodology. How do we conduct this expert consensus, and we highlighted also in the way that we will use the opinion of the ECMO expert through 3 or 4 face-to-face meeting besides the Delphi exercise that we have. And our objective was, as I told you, providing ECMO practitioner worldwide with guidance on tackling controversial topic pertaining to ECMO use for patient with severe COVID-19. So first, I will talk about the faculty. I was very lucky that I have a lot of support from our expert worldwide, started by our senior author, Bob Bartlett. Then we initiated the scientific committee after the Ministry of Health program. They commissioned King Saud Medical City member of Cluster 1 to have this conducting this consensus. The scientific committee consists of 5 experts for more than 5-10 years in ECMO and critical care, including different country in the region of Middle East. Then we for sure get the expertise from our worldwide. We have a lot of eminent experts in ECLS. And finally, we use some guest author to have their experience in formulation of the formulation of the statement, and we want to thank them all for their contribution. And here in the methodology, we started the methodology through, we conducted this consensus through 5 phases. The first phase was a phase of expert composition and literature review. Then we asked the panel to have their question about controversies in ECMO in COVID. Then the second phase was web-based validation. We asked all the experts with us and our faculty to have their validation about the questions that we selected. And it was actually 52 questions. After validation, for more than 75%, we got 32 questions. For this 32 question, we get in a discussion on a 3 face-to-face meeting. There was 2 in Riyadh here and 1 in London. And after that, we reached to around 15 statement that we formulated. This 15 statement was consolidated with the rationale and after getting all the opinion from the expert and the guest author as well. Then we start voting for this statement. It took from us 2 rounds. The first round was Delphi round. We get around here 11 statement, and remaining 4 statement became still weak. Then we conducted the second round until we finalized it with 13 strong consensus and 2 weak consensus on this statement. Then the state of the phase of drafting and writing and the drafting for sure. The paper was published in one of the most important journal in critical care, which is Annals of Intensive Care Medicine. Just stop. Okay. Here in the methods, I want to highlight that we use 2 types of these methods we are using. We are a combination of modified Delphi rounds and the nominal ground technique. And as I told you, it was conducted and coordinated by our center, King Saud Medical City. The voting rule was we have voting anonymous, 10-point scale rounding from totally disagree to totally agree, stratified into low and intermediate and high according to the number of the scores. We allow voter to comment and do suggestion after each round to start to rewording the statement that had not been reached for strong consensus, which is around 4. Then the decision rule, voting with a high score more than 80%, and voting with intermediate score was 70 to 80, and low score less than 70. So total, actually, we have 18 statement, we get 13 strong statement, and the 2 weak, and the 3 we could not reach to a consensus. And I will tell you about those 3 at the end. So at the end, we have we have 5 strong statements. In the domain 1, we have 4 domain, the domain of patient selection and patient management and ethics and logistic. The patient selection, we have a 5 statement. All they got strong consensus from the first round and 1 on the second round. It's simply we discuss it as a intermittent mechanical ventilation before ECMO, which is debatable all the time. And before we find from the literature that before the COVID, the evidence was more with not to put the patient on ECMO if exceeding 7 days because of high mortality with days on mechanical ventilation. But when we check the evidence from our colleagues who are presenting their presentation, like in Spain, and our data also, and the data from Chile, they found that there is no significant difference between the time of intubation. It was within, I think, 13 days. That's why we keep cautious on formulation of this statement, and we said that duration of invasive mechanical ventilation before considering ECMO should not be used as a primary determinant for ECMO candidacy.
However, a longer intermittent mechanical ventilation duration with high setting may help in decision making if it's concurrently considered with other factor indicating a worse outcome. Then the same here, we discuss the scoring system. I have a problem with shifting, so. We have the same in the scoring system, and we could not find a specific scoring system in the literature support COVID. Even we don't have validation for previous to COVID scoring system except RESP score. We find for them extra validation, which demonstrated reasonable discrimination and slightly better calibration. We didn't depend on that also, so we keep cautious also in formulating this statement, and we stated that we don't have any score, and the score also should be used with cautious with other concurrently patient contraindication or relative contraindication. Again, the age, and this was a matter. All the data that we have from COVID, we find that increasing age is increasing with increasing mortality. That's why we face also for a long time constraints of the resources and shortage of resources. And at one time, we have to choose between patients, unfortunately, to put them on ECMO. So I think in many regions worldwide, they use the age as it is a high evidence of on mortality in selecting our prioritization of the cases. And also because of variation worldwide, like Germany, they are liberal, and they put patients who may be exceeding 70 or 65 days. So we keep again cautious, and we advise regional or national policy for controlling the using ECMO according to the age. But we recommended a strong consensus mean score 9.1 with the score rate 90.4. I think was the highest score that we get in this consensus. The Alyaa, again, we stress using the Alyaa criteria, inclusion criteria that we had been used before the COVID. That was because we have some inappropriate use of ECMO as a rescue therapy that we think that it may relate it to the high mortality, and we don't know actually, but that's why we stress highlighted on this in this statement. Then we will go to the second domain, is the ECMO management. It's 4 statement, 2 strong and 2 weak. We discuss also as a controversy. We are discussing only controversy issue in using ECMO in COVID. So you may find something who already had agreement from the literature. So one of them that was which used as a post-ECMO follow-up. We find that follow-up of the patient post-ECMO was decreased after during this pandemic, and we suggest post-ECMO follow-up as a part of clinic or a study to be initiated to assess longer-term outcomes. And we depend on this, and some of our colleagues' experience, especially in India. Dr. Chakraborty in Kolkata, he initiated during the pandemic a clinic post ECMO in the ICU. Then the prone again, we have a lot of issue here where in prone during ECMO, we find in literature for sure supporting good outcome when using prone in ECMO, but the problem was the shortage of staff and the constraint of resources at that time may limit some centers to use the prone on ECMO. And we have also, I think, two meta-analysis for this, one with and the one without. So at the end, after rewarding, it reached to weak consensus that the prone position may be considering during ECMO management in experienced center if there are sufficient resources. Then I think coming a randomized control trial about using ECMO. It was in COVID, about using ECMO in COVID mostly, and we will see the results. And the operational and the logistics, which is matter also here. We have here unique experience in our region regarding the new center during pandemic and the new centralization program during the pandemic. Also, that was because in this area we have lack in ECLS service to the extent we have a lot of countries that lack the ECMO service. So we have some initiatives in some countries, and we followed up with them about their outcome in the new center. One of these countries was Saudi Arabia. As Dr. Mohamed Azzam talked in his talk previously, that he started the pandemic, during the pandemic, a new centralized ECMO program, which mainly was operational as control of resources, patient selection, and ECMO retrieval. And it was a successful story, actually, from the outcome and the data he presented. So we highlighted this also in one statement, which had a strong consensus that centralization is visible to start a new centralized ECMO service in preparation for a pandemic, nationwide or regionally, at least at the level of patient selection and allocation of resources. Besides this experience in our region, also I heard about the experience in Japan. They use a telemedicine, kind of telemedicine, to control and centralize the service. And also in Paris, you use it was new to use an operational management centralized for the machine and the patient selection, I think. So then the new center. And Dr. Azzam also highlighted on the our paper in ICM during the pandemic, which comparing new statement and all the new centers and all centers. It came with favor of new centers. This was a conservative management and some rules of supervision from centralized or other expert center, or maybe even also they provide a lot of support for these centers. I have only just maybe 2 slides. Here they highlighted, Dr. Matt Bedin highlighted in last conference about the new centers and how it's important to stress that it's visible in selected cases, which is the lack of the surface for sure, and providing supervision. Operational also, we have a strong consensus on the transportation of patients with COVID on ECMO. It does not pose an appropriate risk to well-trained mobile ECMO team using appropriate personal protective equipment. Then we have the ELSE statement of supporting the ELSE system real-time registry of COVID, providing virtual training, mentoring, the new ECMO program, establishing a network. In the ethics, we highlighted in the futility that ECMO futility should not be determined slowly by the duration of ECMO run. Therefore, we advise against withdrawing ECMO due to prolonged ECMO until either recovery, transportation, or irreversible multi-organ failure. I think it's logic. Last was the periodization that I started with, and here we cannot find any factor that we are using or any variable to use to do periodization. However, we highlighted that the main common thing is that related to the mortality, multi-organ failure, and with the age is the mainly, which one you can use before the other. This is the problem that we cannot solve during the discussion also. So we come with this statement in such shape. The non-consensus statement that we reached is 3 topics: recommendation to decrease the ECMO cost at least during the pandemic from our partner, and the anticoagulation on ECMO types, time monitoring, and the precise prone failure definition. We discussed all, and we cannot find any consensus or formulation even of the statement. What is the value? As I told you, it summarized most of the experience, best practice, and research during the past 3 years. So it was the last evidence in literature about about what is in the literature and what is the gap in knowledge, guide the next generation with the best practice and preparedness on future pandemic. It helped identify the gap of knowledge, as I told you, and highlight most of the debatable topic, and it guide for future or maybe coming research on COVID-19. We have this visual abstract. I posted it in Twitter and LinkedIn. You can find it summary for all this statement and the methodology. Finally, I want to thank all this faculty and those experts who helped us to come out with this consensus, and then thank you.
Thank you, Dr. Rabie. Thank you, everybody, for tuning for the last 2 hours. If there is any questions or comment, I think from history, the ethical consent, the ethical statement was a little bit looked at differently from people across in the Western area, that why are you including such a statement? It's because of the pressure we see here about the length of stay on ECMO and that they will die. So take them off ECMO and put them DNAR and let's stop, and you're torturing people. And so the history we have, I think we are in a phase where you guys were maybe 15 or 10 years ago, where you introduced with the H1N1 and the big pandemic and the resistance we find. Some people thought that we are actively killing them. To be honest, I'm so proud of the progress that we have. To have Dr. Audat here with us, pro-ECMO rather than anti-ECMO, as he used to call him, is a good progress. So I think now we're ready to die and leave the legacy for the rest of us to take over. Thank you very much. I'm truly honored, and I hope I will be joining you guys tomorrow in the hospital. Cluster 1 hospital is my second home. I'm always there. I don't yet have a badge. Please give me one. I think that's it. If you have any comments, thank you so much. Thank you. Thank you all for coming. And I'm sorry. We have the company have hosted the dinner, so please join us. Those online, please cook your own. And thank you so much. Yes, let's take it.